If you spend time in the outdoors, specifically in a team setting, whether it's recreationally, in a public safety capacity, or even with your group conducting preparedness training, there are natural threats all over, and you should be prepared to deal with them, especially because this one can spiral out of control and kill you.
While documenting the anti-drug military unit's center front, on a remote island 60 miles off the coast, the Hunter Force and their camera crew unknowingly stumbled into a potentially deadly situation. Co-executive producer Mark Allen Johnson is swarmed by hundreds of Africanized killer bees.
Right? Oh, film this. Are you kidding me? Wait, still get me. Oh, get the bees off me. Vámonos de aquí, vámonos de aquí. Sácanos de aquí. Vámonos de aquí, que aquella vea.
Killer bees are incredibly territorial and aggressive. The killer bees now see everyone as a potential target. The only one left with a camera, Ian, is now also swarmed by the killer bees.
Get away from me! Keep going, keep going, keep going! Keep going! Holy sting the at me, go! Go! Oh!
Once these bees sting their target, it releases a pheromone that they can track for up to 2 miles from their hive.
They're following us! Ow! Right on you! They're on you!
The only saving grace is that a rainfall came, and the rain was so extreme that the bees just can't fly. My DP was looking up at me, and it looked like he was gonna cry.
He's puking in a bucket, and they are pulling bee stingers out of his head.
One of the most common minor medical emergencies seen here on the fire line, believe it or not, are bee stings. Due to the fire and smoke conditions, the bees are just in this constant tizzy. In fact, just today, really driving the motivation to make this video on this is that within the span of a few hours, my partner had 2 hornets. One got into the sleeve of his shirt and the other flew up his pant leg, and both stung him. Now, these were minor cases and not a horrible ordeal, but we're going to talk about how this can turn into an extremely serious, life-threatening emergency. And just before I get too deep into the weeds on this, I will preface this by admitting that anaphylactic fatalities are rare, and the vast majority of instances, the patients will do quite well. Nevertheless, fatalities do occur, and reactions that may initially have presented with mild symptoms can rapidly progress. As far as the causes for this, food is the most common cause for children to have anaphylactic reactions, and then you have medication and insect stings, and that's the more common reasons in your adults. So if you're not quite familiar, in wildfire work, there is an absolute ton of prep work that has to get done away from the main body of the fire to get lines established to stop the fire once it gets there. And this involves taking trees down, dozers working through the area, fallers taking your larger trees down, sawyers getting in, the dense brush removed, and then you have your hand crews digging hand lines. Well, this all being done in the woods, And in a case where, if you weren't aware, this is where a large portion of bees and hornets make their nests. So we're just going to go through a hypothetical situation here and say our crew is out working on the line and a nest or a hive is disturbed. The bees go into this, protection mode and start attacking the crew. Obviously, this sucks. Everybody starts freaking out. The members not being targeted by the bees just do whatever they can to get the bees off of the guys who are being stung. Hopefully somebody's heads up enough to grab a CO2 extinguisher and they'll start spraying the victims down, which will kill a lot of the bees. So after that initial chaos of dealing with what happens when you disturb a bee's nest is over, the crew's going to radio for the medics to respond. We're going to show up, and one of the first things we have to concern ourselves with is, are we in a decent enough area to work on this guy? And most importantly, can we get a good initial assessment going on him? So you start with your initial assessment. Obviously, there's going to be a lot of associated pain. You just got stung, up and down. The crew may have done this before you arrive, or you may have to do this once you get there. But we got to get this guy exposed. And once we do, we're going to say that you observe, hives starting to form. And in addition to that, you just have bee stings all over him. Now, I feel like this may get overlooked a lot of the times, but an immediate step that you can take for this patient is to just get them supine. Unless there's some sort of respiratory compromise that would contradict this, getting them into that supine position can help prevent, or at least, start to counteract the impending potential circulatory collapse. So obviously, I have no way to know exactly what your protocols say. However, for ours, they are divided up and separate out mild, moderate, and anaphylactic reactions. And if this is just going to be, a mild one, which would be limited to localized swelling and itching at the site, or you could bump it up to a moderate reaction, and this just tacks on the fact of there are hives present on the skin, or they have some mild wheezing present. For our mild cases, we would just be looking to give that 25 milligrams of diphenhydramine, slow IV push, or probably the more probable route, you're just going to go ahead and hit it with an IM. Or if they have a life-threatening allergic reaction, they have a history of that, to the same allergen that they were just exposed to, you also have the option of just hitting them with the 0.5 milligrams of 1 to 1,000 IM epi to prevent that from forming. If we are leaning more towards that moderate reaction, then we certainly want to get that IM epi in them, but we can also then establish our IV, bump it up to 50 milligrams of diphenhydramine, and we can also go ahead with 2.5 milligrams of albuterol mixed in with 500 mics of ipratropium and just do that combi vent nebulizer treatment. Now, separating this a little further and bumping it up to the next tier, as soon as you start to have any sort of respiratory compromise, urticaria, or acute swelling of the mucosa, hypotension, GI symptoms, then right there we are past what is kind of like a patient comfort route as far as the diphenhydramine goes, and we need to get more aggressive and be proactive because we are now headed into anaphylaxis, and this is why for this we need to know what's this patient's history, what's this patient's pulse, what's their blood pressure, because a true anaphylactic reaction doesn't always elicit a respiratory response where you're going to have the stridor or wheezing or some sort of labored breathing pattern. We could just have a profound vasodilatory shock that we need to treat extremely aggressively. And this is somewhat of a new thought process, as traditionally we have kind of always been taught to focus almost purely on respiratory involvement, which was usually concentrated on wheezing, edema, and swelling in that upper airway. So because it can kind of present in different ways, we have to get this initial assessment done as early as possible. Listen to the lung sounds. Capnography is always a tool that I like to incorporate early on in my patient assessments, and when it's appropriate, of course. But if I hear wheezing or rails and we have vasodilation, it is important to understand what is going on here. So just to clarify, there was an allergen introduced to the body, and the body has marked the allergen. Now, sometimes this can happen over time, and sometimes this can be right from birth, or in this case, we can have just another bee sting or multiple bee stings where all of a sudden we just hit our limit and now react with just this profound inflammatory response. And that's what really causes the problem. So we have what's called these leukotrienes and histamines, and those two types of responses basically cause havoc through our body. The histamine response is what we really focus on because these histamines are going to act in two different ways. They're going to act on our respiratory system in one way and our vascular system in another way. Our vascular system is going to vasodilate, which is when, eventually going to cause fluid leak or fluid creep and cause edema. So now with all this vasodilation going on, we just have this very large container. We have the same amount of volume that we had previously in the beginning stages, but the container has just become that much bigger. In contrast to that, it's also going to cause vasoconstriction of our respiratory system, and that in turn will cause edema of our glottis, our tongue, our lips, and our eyes, and that's where you're going to start having that progressive worsening to where you could have stridor and then eventually just complete airway occlusion. An important thing to keep in mind here when dealing with these patients is that these reactions can vary greatly in how long they take to develop. And here's the important part. There are patients out there that are really brittle, and I would hope that a patient like that would be extremely, very aware that they have an allergy of that magnitude. So that is certainly something to ask the crews before we go out with them. And if you happen to be operating as the medic on your team, you should have this information so that you aren't already behind the 8 ball and trying to gather information on your guys and trying to figure out what's going on with them when it's something you should have already known and had. So getting back to our scenario, if you have this person as a patient and you immediately recognize that this is beyond the moderate reaction and is actually anaphylaxis, this is where we don't want to waste any time with Benadryl and go straight to the IM epi. In a situation like this, and this is certainly a little bit of an exaggeration, but basically all giving them Benadryl is going to do is make you feel better as the medic, because now they won't be complaining that they're itchy. And just as a sidebar real quick about the epi, there was a time, depending on how long you've been a medic for, that we used to give sub-Q epi. But through research, it has been determined that when you are giving epi for cases like this, you need to give it in as deep a place that has the most blood flow as possible. And this is exactly why those people that are issued EpiPens are instructed to deliver it in their lateral thigh. And once that first dose of epi is in, we want to get an IV established, a combi vent neb going, and then 50 of Benadryl, either slow IV or IM. If this patient is hypotensive, we definitely want to do a 20 milliliter per kilogram bolus of LR, or whatever crystalloid you're carrying, and get 10 milligrams of Dex on board, or 125 of Salumedrol, whichever of these two you're carrying. And just for your knowledge base, if you weren't aware, Dex and Salumedrol are the exact same drugs. It's just that Dex is preferred because it has such a long half-life compared to Salumedrol. Once that first dose of epi is administered, we want to go ahead and get an IV established, get a combi vent neb going, and then hit him with 50 milligrams of Benadryl, either slow IV or IM. Now with fluid resuscitation, I know I just said we're going to give that 20 milliliters per kilogram. However, we just want to reiterate and really emphasize the fact that we want to be aggressive here as well. We have become pretty cautious with fluid resuscitation and really not overdoing it with sepsis and with trauma and with burns as well. But here's important to understand, that this is an acute vasodilatory response, so we really have to fill the tank. Now, in addition to all that, we also want to be reassessing this patient every 5 minutes and giving those 0.5 milligram IM injections of the 1 to 1,000 epi as needed until we hit that max of 3 doses, at which point we definitely want to go into an epi drip, which, just as a quick reminder, is made by taking a milligram of epi, either 1 to 10,000 or 1 to 1,000, doesn't matter, mixing that in a 100 ml bag of either Ringers or saline, hook it up to a micro drip, and then have that running at 1 milliliter per minute, which is 60 drops a minute, through a 20 gauge or larger IV, or if you had to, an IO. And while this is running, again, we want to be constantly monitoring this patient and reassessing especially their blood pressure every 5 minutes to monitor their shock status. And if your mean arterial pressure is less than 65 or your systolic is less than 90, then we want to increase our drip to our maximum rate of 2 milliliters a minute, or 120 drops a minute. Once all this is accomplished, if our patient is still hypotensive, we want to contact medical control and probably be asking for additional epi. And really with this, we want that map to be at an absolute minimum 60, because at a map of 60, we know the kidneys are being perfused and should see some response in the heart rate. In addition to all these treatments that we just mentioned that we were doing, we also can't forget that we have to oxygenate this patient, because we have all this leaking fluid and your alveoli are literally being surrounded, very similar to a pulmonary edema or even an acute respiratory distress syndrome. As far as the oxygenation goes and how to do that, you could do it with a non-rebreather mask, but rather than use a non-rebreather, you could also use a BVM, because BVMs pretty much now universally all have positive and expiratory pressure built into them. And this is really important for this patient's airway, because it's being attacked by these histamines, and you're going to have vasoconstriction, edema, and swelling. But on your vascular side, your capillaries are being vasodilated and you're having that capillary leak. Now, this also has consequences in your lungs, because there you're having that pulmonary edema, And so that PEEP is really just going to help with gas exchange by making that surface area larger and helping to push that fluid back out. Now, if despite doing all of this patient is still failing and it looks like we're going to have to take this patient's airway over, that's fine. Obviously, our number one job and goal is to make sure this person maintains his airway, because without that, we really have nothing else. And if a patient becomes this bad or this compromised, you should just expect that you're going to have to aggressively manage this person's airway. Now, if you're in the austere environment, is RSI really a viable option? You know, and if you're not perfectly efficient, could you just end up introducing some trauma and make that swelling even worse? It's just a thought, but instead of the intubation attempt, could we possibly consider maybe using an LMA or even an iGel? And with that, if we don't have any other options, depending on how advanced this reaction progresses, and you have upper airway obstruction from severe laryngeal edema and further progressing to angioedema, then you really have no choice but to correct them. So no matter the case or what you have to do to secure their airway, monitoring the airway with end-tidal is perfect, because you will then be able to see very quickly any changes in their perfusion. So with all that, it is suffice to say, we have done a ton for this patient, and we should absolutely be seeing a lot of improvement, but we have to continue our constant monitoring, because 30 minutes or so later, you could have more of a rebound effect, which is certainly not uncommon in severe anaphylaxis cases. And then if or when this ends up, does happen, and you get another huge histamine release, you obviously have to be ready to deal with that again. So you have to stay alert, you have to be ready for that. And in addition to the constant monitoring and maintaining that, epi drip that we started, we are also going to now have to worry about post-airway management to deal with this, because whether it was a surgical airway or an advanced airway, we are pretty much going to be burning through any and all ketamine that we brought in with us just to keep this person sedated. And in closing, hopefully everything you've done, this is all going according to plan, and through your constant monitoring, you're seeing improvements with our patients. We need to start to evaluate and keep in mind that we have to come back to normal at some point for this patient, because we had that epi drip go in because their blood pressure was low, they were hypotensive. We go in that, now we're going to start to see their blood pressure, starting to creep back up. So once we get back to that normal range, we can't be afraid, or we got to be ready to titrate that epi drip down just to maintain that normal level. With that, I hope you got some good, useful information out of this video. Like I said, the motivation for this was my partner literally getting stung twice while we were staged here today. And I was just like, this is definitely a very realistic threat to anyone operating in the outdoors. So let's share some info and do a video. If you have any questions or comments about this, please leave it in the comments. We will surely respond and get back to you. So guys, go outside, enjoy it, keep training, and as always, be safe.